As I was saying, so we have the entire spinal nerves are divided into 31 pairs, 8 cervical, 12 of thoracic, 5 each of lumbar and sacral, and 1 coccyx. And if you look at the spinal cord, spinal vertebrae, we have got the body, which is the central part. Then you have got 2 lateral extension, which are known as the pedicle, and then you have 2 posteromedial extension, which are known as the lamina. The laminal process fused together to form the spinous process. The space of the shape of the vertebral body, along with the different architectural orientation of the different facets, these are different for cervical, thoracic, lumbar, everywhere. If you look at the lumbar vertebrae, this body will be much larger and the space for the canal will be much shorter or smaller. The cervical and the thoracic, they have this foramen. This is the foramen where through the vertebral artery and the spinal, some of the branches of the spinal nerve, they also go through. But mainly this is the foramina for the vertebral artery. So vertebral artery is present in the upper part. So that's why they are present in the cervical vertebrae. So, and thoracic vertebrae body is generally triangular in shape. So, and they have specific articular facets for the ribs. Anteriorly they got the facets for the ribs. That's how you would kind of identify the which part of the vertebra they belong to. Now they have, the vertebra is also surrounded by various ligaments. If you look at the body, anteriorly you have the spinal anterior longitudinal ligament, posteriorly you have the posterior longitudinal ligament. In between the ligaments or the vertebral body, we have the disc. The disc is composed of a centrally located nucleus pulposus and laterally located a jelly-like body. So this entire disc is in between the two vertebral body. Anteriorly, we got the, as I said, the anterior joint or the facet joints, and inferiorly also they got the facet joints for the inferior vertebral body. Posterior to vertebral body, we have got this canal. This is the most important part of a structure of the spinal cord, or rather the spinal, vertebrae, is that this space between the body and the two laminar process. This area is where the spinal cord lies. So if this area is damaged, we get spinal cord injury. Posterior to this, we got various ligaments like interspinous, supraspinous, ligamentum flavum. So superficial to deep, we got the supraspinous, then you got the interspinous, then you got the ligamentum flavum. Once we pierce the ligamentum flavum, we reach the dura mater, and once we reach the dura mater, we almost reach the fluids, the spinal, the CSF, the cerebrospinal fluid, which is surrounding the spinal cord. So there is the round-shaped spinal cord here, and surrounding it is the layer of spinal, CSF. So this is the overall orientation. So as you can see, now I am dissecting the spinal cord as well. The spinal cord is kind of a oval in shape, elliptical or oval in shape. And in this picture, we get that there are two, one anterior and one posterior median sulcus. Along with that, we get one anterior gyrus and two posterior gyri. And there are multiple areas in which the spinal cord on a cross section can be divided. The spinal cord has its anterior spinal artery, which lies anterior to the anterior median groove, and there are two set of posterior spinal arteries which run in the posteromedial and posterolateral grooves. The spinal cord is also that it emits various spinal nerves. As you can see, the spinal nerves form a sympathetic ganglia. So these are the posterior roots of the spinal nerve which form the sympathetic ganglia. So from the various levels, the spinal cord, the nerves, they carry the different sensations of superficial, deep touch, etc. And then they carry to the posterior column. And from there, they will relay into the posterior horn. From there, they will relay into the anterior horn, and then subsequently into the muscle. Some of the portions of, or the some of the exiting nerves, they will again relay, forming a spinal ganglion, T1 to T2 spinal ganglion, and then they will go towards their end organ supply. As we know already that T1 to T12, the thoracic part is mainly sympathetic outflow, and the lumbar part is parasympathetic outflow. And this, if you cross section wise, if you divide the spinal cord again, so you have got three components: anterior, lateral, and posterior. Anteriorly, you got majorly the motor tracts, the anterospinothalamic tract, reticulospinal, vestibulospinal tracts. But laterally, you get the majority of the sensory tracts, which bring the sensation from the peripheral parts towards the brain, namely the lateral spinothalamic, anterior spinothalamic, posterior spinocerebellar. So they will relay from the peripheries towards the various parts of the brain. The spinothalamic tract obviously will relay into the thalamus and ultimately give projection fibers to the cerebrum. The spinocerebellar tract will relay in the various parts of the cerebellum. Posteriorly, you get two tracts, fasciculus cuneatus and fasciculus gracilis. These are made for deep sensation, deep touch, deep pain, vibration sense, etc. So these various parts, again I'll repeat, anterior is mostly motor, lateral is sensory, and that is superficial senses. The mostly the pain, temperature, and touch. These are the lateral cord, and the posterior cord is mainly for the deep touch, vibrations, joint position sense, etc. So spinal cord, the various functions cord level wise, if you look at it, C5 to C6, for example, this is mostly the biceps brachialis and the brachioradialis. So these are mostly associated with flexion of our arm and flexion of the elbows. C7 T8 is mostly the you're talking about the ulnar. So C7 T8 is triceps, so extension of the arm, extension of the forearm, and C8 T1 is mostly the sensory areas of the middle one third of the arm of our hand, along with the flexion of our digits, and it also supplies the lubricants. So that's C8 T1 ulnar. A nerve is a very important nerve, and it is also called as the musician's nerve for that purpose. Then again, in the lower part, if you look at it, L1, L2, L3 are mostly related to the hip joint. Lower part L3, 4, mostly knee extension. So anterior part of the knee is supplied by the L3, 4. And then lower part, lateral part of the feet, where we strike for the elicitation of the Babinski reflex, the plantar reflex. That's S1. Middle part of our sole is mostly L5 and L4. That's how you differentiate the overall, these are all dermatomal projections. Again, this is not the topic for today, but this is a very, very gross overview of our the different spinal cords, their the spinal cord levels and the tracts as per the anterior, posterior, lateral location, and the various dermatomes. The blood supply, anteriorly we get only one anterior spinal artery, which is a branch of the it can be a branch of various levels. It is branch of various. For example, it is a branch of vertebral artery, subclavian artery in the initial part. Then it is a branch of the great radicular artery. So it is a branch at different levels. It arises from different sections. And posteriorly, we get two posterior spinal arteries. One of the important things to remember is that around about T10 to T12 level, there is one artery which is a direct branch of the aorta, which is known as the Adam-Quist artery, and it is a very large branch. And in patients with severe hypotension or anterior spinal artery syndrome, this artery can get ischemic, and you can have an anterior spinal artery cord syndrome. Spinal cord injury is very common. It is occurring in patients who have trauma or they experience some kind of fall. So these are the main two mechanisms of injury, and because they occur in patients or people who are mostly mobile, so they are more common in young patients, more commonly males than females. Mechanism is either, I said, the traumatic, either falls, or it could be road traffic accident, major vehicle accident. Non-traumatic, it could be because of various other reasons like tumor, cyst, infection, etc. Now, interesting part is that the cervical part is the most commonly affected, and that's how you get paraplegic or quadriplegic patients very frequently after spinal cord trauma. Second to cervical is thoracic is the most common part that is affected. But if someone asks you which is the most common site, particular site where the injury happens, the answer is the junction of cervico-thoracic junction and the thoracolumbar junction. Why? Because cervical spine and the lumbar spine are mostly fixed, whereas the thoracic spine is mobile. So anywhere you have a junction of a mobile part and a fixated part, that part is the most part which is most prone to injuries or trauma. That's why the junction of cervicothoracic junction and the thoracolumbar junctions are the most commonly involved in any form of trauma. As you can see, cervical part, they can involve the phrenic nerve and they can cause quadriparesis. Below that level, mostly what happens is paraparesis. This is a representation of a complete spinal cord injury. Supposedly, someone has cut the spinal cord at some level. What you get is pure motor paresis below the level of lesion, and below the level of lesion, you also get complete absence of sensory stimulus. So, total loss of motor and sensory stimulus distal to the area. If you get a partial spinal cord injury, you can have various permutation and combinations of patchy involvement of motor and sensory nerves. Now, important discussion about the critical care wise. Pathophysiologically, whenever a patient comes, we can divide the pathophysiologically the based on the duration spinal cord injury into two parts. One can be an acute phase, which is between say 2 to 4 weeks, and beyond that we call it a chronic phase. So the importance is that during the acute phase, we are dealing with the primary cord injury itself, and we want to prevent the secondary cord injury. If you can if you can recall from the previous class about the brain injury, traumatic brain injury, our motto was to prevent the secondary brain injury like hypoxia, cerebral edema, electrolyte injuries, excitotoxicity, etc. Similarly, here also the same concept applies. We want to prevent the secondary injuries, and notably there are two important phenomena, which is obviously that's why the class is being taken today. That is spinal shock and neurogenic shock. This will be discussed in details. There is some term known as unstable cervical cord injury. SCI stands for spinal cord injury. Sorry. So what is an unstable spinal cord injury? So if you look at this picture, this spinal cord column can be divided in three parts: anterior anterior spinal ligament, longitudinal ligament from there till half of the vertebral body. This is anterior column. Posterior half of the body till the posterior longitudinal ligament is middle column, and from there onwards the posterior part is the posterior column. Importance is that the most vulnerable region is the middle column, followed by the anterior, and the least vulnerable is the posterior. So if you have a fracture of involving the middle column, or you have 2 out of 3, you have disruption of 2 of 3 columns, then you call it an unstable fracture. Very, very important. Why? Because whenever you diagnose that it is an unstable injury, you have to immobilize the spine, call the neurosurgeon for immediate surgical fixation, because later on the neural injuries are going to aggravate. So this is the importance of an unstable spinal cord injury. Now, when we talk about the injury, different types: primary, secondary, spinal, neurogenic. So primary injuries, whatever the mode by which the spinal cord has gotten affected. That could be a flexion injury, like for example, someone has hit the windshield and then their neck is hyperflexed, or it could be a windshield injury which causes extension injury. Someone having a deceleration injury, suddenly someone put the brakes on and then their head goes and collides with the windshield, and the head kind of rotates backwards, suddenly causing a hyperextension injury. Could be a combination of flexion and extension injury. Their head can rotate as well as flex at the same time, causing a flexion rotation injury. That can also go sideways and also can hit any of the wall or the door. So that can cause a lateral injury. So various forms of injuries, various mechanisms can cause various levels of disruption. Secondary injuries is what we want to prevent: the hypotension, the hypoxia, the cerebral cord ischemia, similar to what we have learned in brain injuries, similar mechanisms. So in acute phase, we are dealing with mainly two important particular components, that is a spinal shock and neurogenic shock. Now the easy ways to remember for you guys is to remember that spinal shock is dealt with the spinal nerves and neurogenic shock is related to sympathetic system. Spinal shock is when you cut the spinal cord at a particular level because of injury, the neural supply, the sensory and the motor supply is gone. That is simply the spinal shock. So it is a flaccid paralysis, areflexive paralysis below the level of lesion with associated loss of bladder and bowel control. And so alongside there is a loss of vascular tone, you got vasodilatation and hypotension because of that. So the spinal shock is obviously followed later on by something known as an ADR, autonomic dysreflexia, that we'll have a discussion upon. So spinal shock is simple. If you cut the nerves, there will be no sensory and motor outflow or inflow, and that will cause a spinal shock. Stages can be divided into 4 stages. Initially, in the initial part, there is complete areflexia. So you don't have any reflexes below the level of lesion. So supposedly someone has spinal cord injury at cervical spine C5, C6, below the level, whatever the reflexes are areflexic, the bladder and the bowel is not, well, I mean, there is no sensation at all. They are also areflexic, they are distended. You have to put catheter for that purpose. Bowel is also distended, and the plantars are mute. There is no plantar response. After that, there is some initial reflex that returns in 1 to 3 days, following which you get something known as the early and then late hyperreflexia. Generally, by 28 days, you get early, and then after 28 days, you get hyperreflexia. So, the return of reflexes, but this time they are out of their inhibitory control. So they have a like C5, C6 level. If you have a cutoff, above that there were a lot of inhibitory controls which were controlling the downward centers. Now because that controlling mechanism is gone, they will go haywire and they will have increased reflexes. So beyond this, generally a day 4 to day 7 period, you get increased reflexes, increased. You can have clonus, you can see plantar extension, you can have excessive bladder contraction, hyperactive bladder, etc. You can have. Now, as I said, spinal shock is related to the loss of sensation. Neurogenic shock has to do with the sympathetic loss. What happens is that it is seen purely if you have a lesion above T6. As we know that there is a mnemonic that is sympathetic is thoracolumbar, parasympathetic is craniosacral. So the the sympathetic discharge is thoracolumbar. So from T12 to T1 to T12 and L1 to L5, the spinal ganglion is the one which has the sympathetic relay chain, and that provides a sympathetic outflow to the entire viscera. Parasympathetic, on the other hand, has two sides. One is cranium, the vagus, and the sacral, that is S2 to S1 to S5. Therefore, when you have a lesion or cutoff around T6 and above, so your majority of the sympathetic outflow is gone, and like T6 below, entire chain is gone, and because of that you have decrease in the sympathetic overall outflow. So decrease in the epinephrine, norepinephrine, you get reflex bradycardia because your sympathetic system is down, parasympathetic takes the upper hand, and you get vasodilatation below the level of lesion, causing pooling of blood in the lower limbs, causing hypotension. And this is one of the important things to consider whenever you are managing a spinal cord injury patients. So spinal cord injury patients, immediately post spinal cord, 6 to 7 hours after that, they will come to you, you will intubate, and they will go into bradycardia and arrest. This is because of the neurogenic shock. So bradycardia and refractory hypotension, not responding to fluids, is the initial sign this patient has got a neurogenic shock. Just to again reiterate, neurogenic shock is the fourth type of shock that we know about, or rather the second type of shock among the distributive shock. So we know that among shock can be of obstructive, cardiogenic, hypovolemic, and distributive. Among the distributive, one is septic, and this one is the second one, the neurogenic shock. So this will just behave like a septic shock, except that there will be no signs of fever. So there will be bradycardia, there will be hypotension, and vasopressor refractory hypotension. So for that purpose, what we need to manage in neurogenic shock is start a positive inotropic agent. So you start an ADR infusion, like adrenaline infusion, or you start a dopamine infusion. In our present scenarios, present current practices, there is almost any use of dopamine per se, except for this scenario, where dopamine acts as a positive inotrope, positive chronotrope, and a positive vasopressor. So triple action. So dopamine is preferred in these cases. Now, if you look at the various level wise, and imagine that your C3, C5 is supplying the phrenic nerve, C5, C6 the upper torso and the muscles of the arms and limbs, along with the thoracic cage, and then you got the thoracic level that is supplying the intercostal muscles and the abdominal muscles, and then the lumbar which supplies the obviously the pelvic splanchnic nerves, the genital areas and all. So, if you get a higher up injury above C3, your spinal cord, splenic nerve will be gone, and you have a reduction in the vital capacity, and obviously your cough reflex will also be weak, and these patients land up in intubation, ventilation, tracheostomy, and not even tracheostomy. These patients mostly they don't breathe on their own nicely, and therefore they need lifelong invasive ventilator support, invasive BiPAP support. Sometimes they need diaphragmatic pacing. Below C5, if the diaphragm is spared, their vital capacity is somewhat maintained, their cough is weak but still present, they can avoid intubation in rare scenarios, but again, because of the intercostal muscle paralysis, they require intubation. Now here, I will want to share you one clinical vignette. Patients with high cervical spine injury C3 to C4, they will have phrenic nerve injury. So their diaphragm will be pushed upwards. When you examine them, you will see that they're vigorously having some kind of obstructed breathing pattern. Although their saturation levels initially will be normal, their pulse oximeter will have normal tracing. In these cases, you have to examine them clinically, ascertain the level of lesion. If you see that their upper limbs are entirely weak, upper limb flexor, digit flexor, and the extensor muscles are extremely weak, flexion of the biceps or biceps triceps function is weak, that indicates that it is a high level cervical lesion. Along with them, you do something known as a single breath count test. If your single breath count means you ask the patient to take a deep breath and name as much as numbers that is possible. If they can name more than 25 numbers, means their expiratory muscle power is good. They will not require intubation. But if their single breath count test is less than 10, and or if they have carbon dioxide retention, don't go for the invasive BiPAP and wait for them. Just go for intubation because these patients have severe phrenic plus minus along with an intercostal muscle weakness. Same thing holds true for these patients also, where you get partial muscle weakness, but you have some amount of intercostal weakness as well. They can also end up in ventilator. Above T8, phrenic nerve is spared, but again intercostal nerves are weak. So these patients, especially if they have comorbidities like a COPD patients require excessive amounts of expiratory muscle workload. If their intercostal muscles are gone, these patients can retain carbon dioxide, can go on in a ventilator. And below T8 to T10 generally is safe because your intercostal majority is spared, and therefore respiratory wise they are safe. Otherwise, but however they have paraparesis. And there is a paradoxical improvement in vital capacity in supine position. This is one classical thing that happens in these patients. So if you make these patients ramp up semi-recumbent position, head up position, they will have low vital capacity. Why? Because the moment you make them supine, abdominal viscera will push the diaphragm towards the upside. Now because the diaphragm is having paralysis, because of the pushing action, they will also have a reduction of, or rather a drag of the diaphragm when their abdominal viscera move distally. So because of that, they have increased diaphragmatic excursion in supine position and better vital capacity in supine. So nurse them in supine position. There are two reasons for it. One is the better vital capacity. Another is obviously maintaining the integrity of the spinal cord, especially in unstable spinal cord injury. What are the other complications that we know about in these patients? You can have pulmonary edema. Mechanism are mainly neurogenic, that sudden onset neurogenic surge, sympathetic, parasympathetic discharge, stress on the heart causing pulmonary edema, or it could be simply volume overload because of excessive fluid resuscitation. Other than the fact, these patients have very high risk of DVT formation because these patients they don't move, no movement at all. So these patients develop DVT. If you don't treat these patients with anticoagulation, they can develop DVT as high as 54% of cases. And with all these sequential compression devices or DVT pumps, the percentage is almost as high as 27%. Only with anticoagulation, there is a reduction in the rate to below 10%. So you have to apply chemical and or like therapy, prophylactic pharmacological anticoagulation with enoxaparin or heparin in these patients. Other than that, you can have trauma-related other complications. Now coming to again to reiterate the importance of cardiovascular findings, these patients can have severe bradycardia because of the loss of cardio-accelerated fibers which are from T1 to T4. These recover by 3 to 5 weeks only to give way to something known as an ADR, autonomic dysreflexia, that we'll discuss later on. And because of the severe refractory bradycardia, whenever you are doing anything to the patient, like position change, like putting a mask on the patient, or suctioning the airway, they can trigger the vagus severely, causing significant bradycardia and asystole. And therefore, you have to keep ADR atropine ready at the bedside and always do minimum stimulation as much as possible. If the patient is intubated, go for a bolus of sedative like fentanyl bolus before you suction the airways. Hypotension refractory to vasopressors, as I said, dopamine or ADR anything can be used. These patients are also typically have a very high incidence of peristaltic, like hypoperistalsis or ileus. This is an interesting part. This is one of the very common reasons of having IVS. Because of the high cervical spine injury, they will also have significant loss of the gut motor activities, and the gut parasympathetic will go down and sympathetic will go up. That will cause the ILS kind of scenario, and they will have distended stomach, they will have distended duodenum, small bowel, and as well as colon. So this paralytic ileus is a significant problem to deal with. You have to initially try with correcting the other factors, like if there is a concomitant hypokalemia, hypomagnesemia, you have to treat them, and then start very slow and low volume of feeds. Along with that, you have to use adequate dose of prokinetics in these patients. So after the initial period, so just to memorize for easy for making your understanding easy, if a spinal cord patient comes to you, your initial assessment should be the airway and the level of injury. If the patient requires intubation, go for it. Don't wait for the NIV to work, or carbon dioxide. If the patient has slightly elevated carbon dioxide, that is enough to tell you that you have to intubate immediately. Don't wait for the carbon dioxide to go beyond 50, 60. Second thing is to remember is that these patients can have bradycardia and hypotension at the presentation itself because of neurogenic shock. So you have to prepare your positive inotropic agents as early as possible. During intubation or any procedure, you have to keep them ready. Third, these patients have very high risk of DVT, so give an anticoagulation. Fourth, very high risk of paralytic ileus, so giving soft tide, giving a laxatives, keeping the bowel open is very important. Once the patient recovers from this acute phase, they go into something known as a chronic phase, where you have something known as autonomic dysrespiration. What is this phenomena? This is a massive disordered autonomic dysfunction or response, generally from below the level of lesion. So if you have a spinal cord injury at your neck, C5, C6 level, below the level of lesion, any noxious or non-noxious stimuli can trigger this reflex. So imagine that your nerves were actually died or they were not active. After they have healed, they have become hyperactive, and that's why this phenomena occurs. Incidence is as can be as high as 60% in cervical, and the basic mechanism is that imagine that you have a spinal cord injury at a certain level. Below the injury, you got any noxious stimulus. Your bladder is distended, or the patient has an impacted stool, patient has an UTI, patient has a pinprick, anything. And that the afferent fibers go by the sympathetic chain, they relay into the spinal cord ganglion, the anterolateral part, they relay to the ganglion. At, that is the afferent stimulus, and they form a reflex arc like everyone does, and the effector response is by the motor response. Now, from the brain, inhibitory signals are normally relayed to each and every spinal cord levels, like our Babinski sign. If your inhibitory reflexes are gone, then your excitatory reflexes are overwhelmingly superior to your inhibitory reflexes, and that will cause abnormal phenomena. So, because of the sympathetic stimulation, what will happen is above the level of lesion, there will be a hypertension, increased vasoconstriction, and that will cause reflex bradycardia, because your this inhibitory signals don't work, but your blood pressure, these things are getting sensed by the glomus receptors and the carotid bodies and the glomus bodies, and they activate the baroreceptor reflex. They sense that the blood pressure has gone up, they will cause bradycardia. Similarly, they will have intense sympathetic stimulation everywhere below the body, below the level of lesion. They will have piloerection, also known as the goosebump kind of feeling. They will have pallor, and abnormal pallor and flushing, both can be possible. Above the level of lesion, what we get is refractory bradycardia, headache, flushing, etc. So that's a very important thing to remember. Triggers are mostly bladder distension, UTIs, an impacted stool. As I said, that noxious stimuli, they will stimulate the sympathetic system below the level of lesion, causing a sympathetic discharge, but which is uninhibited. Above the level of lesion, baroreceptor stimulation, parasympathetic stimulation, vagal stimulation, bradycardia, and flushing. No hypotension, hypertension. So generally, on headache, flushing, bradycardia, piloerection. These are the major cardinal features of this phenomenon. And the more the chordate involvement, the greater is the effect. And therefore, how can you manage it? So remember, if someone asks that, okay, patient is paralyzed for 10 years, patient has got a spinal cord injury, paralyzed, and you want to do a surgery in the lower limb, do you need anesthesia or not? The answer is yes, because even if they are paralyzed, they have this ADR which is activated, and that can cause significant hemodynamic perturbation. So you need to block those nerve endings. So you need to go for check 1, 2, 3, 4, 5 like a checklist. Check for blood registration, go for catheterization, plus the catheter. If you have go for a digital rectal examination and rule out an impacted stool, go for a laxative enema. Look for any kind of occult focus of infection, any UTIs, any kind of perineal abscess, etc. Because this patient won't tell you, because they are paraparetic, don't have any sensation. They won't tell you I have pain in that particular region. So you have to examine yourself. And after that you have ruled out, you have to curtail the hyperdynamic or hypertensive response by giving sublingual GTN or IV GTN, and then adding some antihypertensives like hydralazine and calcium channel blockers, etc. And one important thing for the MCQ purpose, especially from anesthesia point of view, is that these patients, once their nerve endings gets damaged, their motor end plates gets regenerated and they develop neuronal type of choline receptors, acetylcholine receptors. These receptors have high affinity for the acetylcholine and they get stimulated to reproduce higher amounts of potassium. So they release higher amounts of potassium from the motor end plate, and that can cause significant hyperkalemia. So the question is, and that happens with only depolarizing muscle relaxants like scoline, suxamethonium. So suxamethonium is avoided, or rather should be avoided, in a patient with spinal cord injury. So it can be given, although within 3 days or after 2 years of spinal cord injury. So if you have to give, you give it within 3 days or you give it after 2 years. But in a banner statement, what I can make out, avoid scoline at all cost in these patients. So it can rise to dangerous level of hyperkalemia and it can cause significant cardiac arrest also. In general, management of trauma patient is mostly symptomatic. In the initial period, you manage hypotension, bradycardia, spinal shock. Intermediate phase, you manage the autonomic dysreflexia, and along with the, other than the infection part, the hyperkalemia from scoline part, and chronic part, you are mostly worried about the contracture fractures, the hypercalcemias, osteoporosis, etc. Now, this is one of the visual representation. These are our teachers. The left hand side, ma'am is a famous trauma anesthetist of her own. So she's demonstrating how a trauma patient is log roll test. This is known as the log roll. So see that cervical collar is applied and everyone is touching the body. One person is holding the body from opposite side. Two persons actually. Another person is watching. And at this entire point, nowhere that there is a torsion at the spine. So entire spine is actually moving as a unit. This is important. One important nuggets is airway management can be tricky. So always go for a rapid airway management technique. You cannot do a head extension in these patients. You can do chin lift, but you cannot do neck extension. So that is one important thing. Always apply MILS. I think taught this thing. MILS stands for manual inline stabilization. Whenever you're intubating a patient who has a spinal cord injury, ask a colleague of your own to stand on the right hand side of the patient and hold the head like a cradle. So their finger should be beneath the occiput, their palm should be beneath the jawline, and that should give a force. The direction of the force should be to oppose your intubating forces. That actually cancels the extension of the head that can happen with intubation. Other than that, you can go for rapid sequence induction because of these patients can have gastroparesis, full stomach, etc. Scoline is avoided. Use of videolaryngoscopes or airway adjuvants as early as possible is recommended. This is how you do a manual inline stabilization. One person doing an intubation, one person handling the head like a cradle. Alternate plan, if you fail in intubating, we can use a light one. You can use intubate through the laryngeal mask airways, or there are other techniques as well, but this is particular for the anesthesia part. What is the Asia scale for spinal cord injury? Asia stands for American Spinal Injury Scale. This does not stand for Asia as a continent. This is one important thing. So Asia is actually American. There are 5 grades. Asia A is the worst one, where you have complete loss of spinal neural and sensory function, at least at the level of S4, S5. And grade E is what is called as normal, where your motor and sensory functions are normal. Regarding the management of blood pressure in these patients, we have to keep a blood pressure to maintain a perfusion of the spinal cord. And we have taught in previous classes that perfusion is dependent on the upstream pressure minus the downstream pressure. So the downstream pressure is the intracerebral cerebrospinal fluid pressure, and upstream pressure is your mean arterial pressure. So you have to subtract the CSF pressure minus from the mean arterial pressure. That will give you the pulse pressure. So as I was saying, the spinal cord perfusion has to be maintained. So MAP minus CSF pressure is the one that should be maintained. If you don't have a CSF pressure to measure, you can take it as a surrogate like 15. So if you target your adequate perfusion should be 15 plus your MAP minus 15 should be at least 70. So it should maintain a MAP of 85 to 90. That's how you maintain a perfusion of around 70. And other than the fact, mostly I have already covered. You should avoid hypotonic fluids like you avoid in brain injured patients. Steroids useful. Previously, there was lot of trials of using high dose solomedrol, that is methylprednisolone, in acute cervical spine injury patients. Then data came that use at after 3 to 8 hours window period is actually harmful, and within 3 hours you can use it. Later on, it was found that the risk outweighs the benefit. So there is no role of using high dose steroids in cervical spine injury patients after trauma. Analgesia, it is a multimodal approach. You can use opioids, you can use NSAIDs, paracetamol, your choice. Regarding spinal cervical spine, there were some few extra points, but I don't think that this much depth is important. I'll go to the next section of today's class, that is burn injury. Okay. Any question as of now? And the last class on 16th I took, that was on brain injury, traumatic brain injury. Traumatic brain injury is actually quite a vast topic. I have focused on the important points and the BTF guidelines, but there were many fundamentally challenging conceptual things which were there in brain injury patients. So if anyone has any doubt, they can ask at the end of the class. So I'll proceed with the burn part. So management of burns. The topics I'll cover is epidemiology, from epidemiology to fluids to antibiotics to nutrition, and after that, the post-burn care. I'll skip the boring part. I'll come to the mechanism. So classification, burns injury could be of 4 types. It could be because of direct heat. Someone is exposed to a hot a fume. It could be a direct flame, or it could be a scald, a chemical, or hot water, or splash. So that could be a wet heat, or it could be dry heat. Dry heat is direct heat. Wet heat is something like hot water or hot milk falling over a body. Then you got electrical injuries, mainly the lightning injuries, or someone touching a high voltage current, like for example your AC transformers or any kind of high voltage wires. Especially, it is very common in the monsoon to get children electrocuted very commonly. So the electrocution injuries is in particular is interesting in the sense that whenever the electricity enters your body, they try to find the path of least resistance. And most of the time, if you are touching a wire which is high voltage wire, the pathway will be from your arm to your heart and come out through the other arm. And that's why your heart comes in the way of the pathway. And most of the time they don't get electrocuted, they don't die from the burn, they die from the immediate cardiac arrest. And if they are resuscitated, CPR is given immediately, their lives are saved. This is an important lesson. But obviously, the first and foremost thing is to detach them from the source of electricity. The strength and the voltage obviously is very important, and the highest that is possible is obviously a lightning injury is mostly fatal. If you ever get to see a lightning injury with a patient who has survived, you will see that the depth of injury is very important. Another very interesting thing that just came into my mind is that these injuries are not extensive, but they are deep. What do you mean by this is that burns mostly have an extensive skin area covered, but these electrocution injuries, they rarely have an extensive skin involvement, but they have very deep skin involvement. And that's why many times their level of injury is mostly underestimated. We think that, okay, they have only the leg involved, therefore their fluid requirement is less. Actually, it is the reverse. They have deep injuries, muscle deep, bone deep injuries, therefore their fluid requirements are quite underestimated. Sometimes you can have chemical injuries. Some chemical can fall on your body that can cause significant harm. That can cause, one is that chemical injury itself can cause burn, and two is that it can cause various cellular level injuries. One thing, decontamination is very important in the primary survey in these patients, that you have to douse them, you have to remove their cloths, wash them, and then you have, as a healthcare professional, you have to attend them. Similar thing applies to radiation injury as well, that the healthcare workers are at increased risk of radiation exposure. What is the burn depth and extension? We know that our skin is composed of 3 layers: the super epidermis, dermis, and the subcutaneous tissue. The epidermis has got 5 layers: stratum corneum, stratum lucidum, stratum basale, stratum spinosum, and there are 5 layers such. I forgot about the 5th layer. Similarly, your dermis has got various neural bundles, and blood vessels, and different fatty layers, connective tissue, and that subdermis, the subcutaneous tissue, contains the fat, and then you have the muscle layer and the bone layer. So your burn injuries are also classified based on that. Now focus on this thing. Burn can be classified as 4 grades: superficial, partial, deep, and deeper. Full thickness and deeper. Superficial is when you get minor injuries like a flame injury and supposedly minor scald injuries, where you get only redness of the skin, erythematous skin. The stratum corneum, or rather the epidermis, is affected. They are very, very painful, but they heal very faster, and they are generally mild. They don't get infected, and they have a very good outcome. Nonetheless, they don't. These patients generally don't come to hospital altogether. But the next part is the important burns. Important about the depth of burns is the partial and the deep burns. Partial can be divided into partial superficial thickness burns and partial deep thickness burns. Someone who has a blister on the burns. Blister means fluid accumulation beneath the epidermis. So whenever you see a blister, that has to be at least a partial thickness burn. It cannot be a superficial burn. If you see a blister and if you see a burn injury which is exposed and blanchable kind of skin, which is reddish, more of reddish, that is superficial partial thickness burns. These are painful. They heal by 3 to 7 days. Then you get superficial deep thickness burns, or deep partial thickness burns. Sorry, so not superficial, deep partial thickness burns, where you get blisters. The underlying of the burn area would be wet or waxy in appearance, and they are blanching, but generally blanch less as compared to superficial partial thickness burns. They are also painful. They heal by around a month, 21 days to 28 days. And beyond this, full thickness burns, they will have various grayish, waxy appearance. The subcutaneous fat will come out, muscle layer can be exposed. So these two can be clubbed together as deep burns. Then generally charred eschar formation is there, muscle and deep bone, deep burns is there. Sometimes bone deep burn and fractures are there, and they are generally painless because nerve bundle is affected and they are painless. But obviously, prognostically, they are bad. Now, the phases of burn management. If a patient has come to you, your initial phase 1 is your resuscitation as per the ATLS protocol, ABCDE. Phase 2 is the fluid resuscitation as per the burns. Phase 3 is your burn wound care and the infection part. And phase 4 is the rehabilitation part. When a patient has come, initially you triage them. After you triage them, you apply the ABCDE formula as per the primary survey. And in the primary survey, you look for the inability to maintain the airway. There are signs, symptoms. I'll come to that later. In the breathing part, you look for any kind of abnormal breathing, decreased breathing. You will assess the circulation. You will start resuscitation. You will move the patient from that place to another place. If you are at a area where the burn is still occurring, you should douse the burn site by cold water. So these are the various ways by which you are attending your patients with respect to primary survey. One small off the track discussion is that how you do prognosticate your burn patient. So this is an interesting thing, and I don't think the burn textbooks mention this. There is something known as a modified box score, BAUX. So if you get a burn patient coming to you, there are 3 things you need to look at. Okay, one is the patient's age, the percentage of body surface area burned. We'll have a discussion on that, and then if there is inhalation or injury present or not. Modification of box score included this inhalation and injury part. And you simply, what you have to do, there is a scale. You take a sheet of paper, you take the age of the paper, and then you have to apply the age of the patient along with the body surface area burned, and then you can easily get to where your estimated mortality is. So supposedly your revised box score is coming to be around 140, your estimated mortality will be 85. So supposedly this way you have cut. So there is an age, there is the percentage body surface area, and from there if you cut a section, that will come to this. So this is how you ascertain their burn injury or prognosticate. Again, continuing from the primary survey, ABCD approach, these are already said. Now particularly there is a criteria which tells us which patients should be referred to a burn center. So If you get a burn patient, your first duty is to stabilize and refer. If you're not dealing in a burn setup, so reference criteria are patients having partial thickness burn more than 10%, any pediatric burns more than 5 to 10%, deep burns, third degree burns, electrical burns, chemical burns, radiation burns, burns in a patient who has significant comorbidities like COPD, heart failure, etc., and burns associated with significant trauma. These are mostly, common sense you can apply, but mostly you have to remember partial thickness more than 10% and burns involving important areas like face, hands, genitalia, etc. They have to be referred. So in the airway, you have to assess for something known as the inhalational injury. Now you have to intubate burns patient in three scenarios. One is that patient is having significant burn injury and the airway involvement. How will you assess whether there is an airway involvement or not? So if there is nares, patient's nares or the noses are red and there are soot materials, blackish carbonaceous materials which is there on the nares. There is singeing of the nasal hairs. The airway, mouth is also kind of blackish. Patient is having hoarseness of voice. This means that the patient is having an airway burn. In this case, we can go forward and do 2 to 3 things. I'll discuss this later. But these are the signs which indicate the patient is having a possible inhalation and injury. The second thing which can prompt an intubation is a intoxication of because of gases like carbon monoxide and cyanide. I'll have a detailed discussion later on. So, and third is if you have a patient with other trauma like severe brain injury along with burns, that can happen. Patient has gotten burned, then fall into the ground and has severe head injury, that can also end up in intubation. So, as I said, persistent cough, stridor, patient having breathlessness, patient having significant nares and singeing of hairs, and there is any kind of evidence that the airways, oropharynx is having blackish material deposition, etc., you intubate immediately. So, after you have already ascertained the patient's airway, breathing, circulation, etc., you have to take a short history during the secondary survey where you have to ask about the modus or the mode of burn injury, whether there was a closed environment or not, what is the extent, is there suspected pregnancy and any other injuries like trauma, etc., is there or not. And lastly, you have to ascertain the AMPEL history. AMPEL I've talked in the trauma section. AMPEL stands for allergy, medical history, previous medical or surgical history, last meal taken, and any events leading to the trauma. Extension of burn injury can be evaluated. Now, this is an important, interesting part. Extension of injury of the burn can be evaluated based on various formulas. Most commonly used is a Wallace's Nudum 9. Second most common is a Landau-Browder chart. And third is the palm rule. Now, I'll just tell you one simple hack. Don't try to memorize these percentages and all. If you want, you can memorize the Wallace's rule of 9. That is well and good. Every equipped burn center has their own chart. So they will stick the chart on the front of the patient's file. You have to just, draw a sketch in showing that which parts are. You look at the patient and draw the sketch and then you calculate yourself. You don't have to memorize, okay, this part is this much, this part is this much, and this part is this much. That's how some this much. This is not always the case. So, as we have known from our forensic medicine classes previously, that your Wallace's rule of 9 appoints 9% for the anterior and the posterior part of the torso. Entire one upper limb is 9%, and each lower limb is 18%. So the torso becomes 36, each lower limb 18, 18, 36, 72, upper arm both the sides 18, and head and genitalia 9 plus 1 is 10. So that becomes 100%. In pediatrics, the relative size of the head is larger than the other parts. Now, one important thing which we forget, that female patients who have heavy breast, especially beyond 34D size, and they can have significant burn involving the breast. And if we only measure the surface area based on this Wallace's rule of 9, we will underestimate because their breast size is huge. So there are some formulas which take care of this part. You don't have to go in depth, but just know that the brachial size or Longley size is also important while considering your burn surface area. Depth of burn, if they are unsure about the depth of burn, there are various methods like laser Doppler analysis, thermography, indocyanine green technique. These are all theoretical tests used in properly equipped centers. But to be very frank, I've worked in one of the best centers in burns. but I have not come across these techniques as of now. Now, what about central line insertion and these patients? Okay, now let me give you a 2 minutes. I'll go for detail from the topic. I'll give you a real time example of how to manage burn patients. Burn patients who are severely burned and whole body is charred, they will have significant problems in terms of applying monitors. Whenever a patient comes, you apply ECG, pulse oximeter, like that. They will have denuded skin. They will have skin dropping off onto the floor. Entire skin is denuded, raw areas. You won't have anywhere where you can apply an ECG. You will have difficulty in measuring blood pressure. You will have difficulty in picking up the pulse oximeter. And therefore, uh, after hypothermia prevention, that is one of the things that you have to maintain in these patients, that you have to cover them, keep the room temperature a bit higher. What you have to do is be a bit smart. So apply ECG whenever you can get a chance, not always. Apply pulse oximeter to anywhere you can find where there is an unaffected area, and put an invasive arterial line, because you cannot measure BP always. These patients are hugely dynamic. They can have hypotension anytime. They can crash anytime. So put an arterial line. Now, regarding the line axis, you can choose between a central peripheral, fine, but you have to secure a line. If the patient has 90% bounce, you have to secure a central line. When you are securing a central line, you choose a side which is not affected by the burns. Very important. So if you have a head neck burn, choose the femoral. This is very common in the pediatrics. Pediatric patients, they will have scales because their hot milk will fall over their body. They will have scales in the upper part. But their femoral groin area is spared. Do a femoral central line. If the femoral area is involved, do a neck, jugular, subclavian, whatever knife. You can improvise. You can put central line through peripheral veins like saphenous vein also. This has also been done. So you have to improvise. Another important thing to remember is that these patients, because of the denuded skin and all, you cannot just prove volume assess immediately. You cannot go for cardiac monitor and all. So you have to rely on your hard static findings, static parameters to assess fluid responsiveness. And if you're using an echocardiography, sterilize them, put inside a plastic cover before you use. Otherwise, you will end up infecting the patients. So managing these patients in terms of very basic things like monitoring, echocardiography, volume assessment, these are also very much tough. So be very active and also use your brain at every point of time. This particular trial has evaluated whether central line can be done through a infected site or affected site. Yes, it can be done, but there is very high risk of infection, central line associated infection. So if you are putting a central line through the burn site, change it by 2 to 3 days routinely. Don't wait for the infection to set in by 7 days. So in a burn patient, you put a line, change it by 2 to 3 days. Now, important topic of discussion. Now I would want everyone to focus again. Fluid resuscitation in burns patient. One MCQ, if from trauma burns can come, this is one important topic that can come. Fluid resuscitation is important. I am not going into the basic things like if you underfill the patients, they will have hypovolemia, they will have end organ hypoperfusion, lactic acidosis, they will die. If you overperfuse, they will have pulmonary edema, and so and so. What I want to focus on is that initial period of burns patient, they have something known as the F phase, EBB, and then later on, after 2 to 3 days, they have a flow phase. During the F phase, they have hypodynamic circulation. So they will have some myocardial suppression because of the increased inflammation. They have certain amount of vasodilatation as well. So it is not straightforward resuscitation. So during the initial period, they have a shock that is multifactorial. One is that the severe inflammatory reaction, significant denudation of skin that cause evaporative loss, as well as myocardial suppression. It is not always hypovolemia. Myocardial suppression also works, that generally gets recovered by 24 to 48 hours. Rapid and aggressive resuscitation in the initial period is important. Delays is associated with increased mortality. What are the different formulas? Initially, there was a historical Evans formula, then came the Brooks formula, then what we use modernly is the Parkland formula. Parkland is how we will calculate 4 ml per kg body weight per body surface area burned. So if you have a patient who has 50% body surface area, weighing 50 kgs, and then the formula will come to 4 into 20, 50 into 50. That will be around 10 liters of fluid that will have to be given over 24 hours. Next thing to remember, half of the fluid has to be given in the initial 8 hours, rest half in the next remaining 16 hours. So it is not 12 and 12, it is 8 and 16. And then in the follow-up period, if your patient is stabilizing, you give second half, you give 20 to 60%. Round about half to one third of the required fluid in the day one, you can continue on the day two, along with some amount of colloid if you are ready to use. These are the various formulas and their comparison. Initial Evans groups, they had various limitations. Their studies were not good enough or other powered enough. Parkland was hugely hit. Everyone started using Parkland. It became a hit. It became an MCQ question. But later on, it was found out that if you're using at 4 mils per kg per body surface area, that's Parkland, you're actually ending up giving a bit more fluid that is actually required, causing excessive fluid creep and third spacing. What we can do is that Brooks formula had 2 mils per kg and 1.5 mils per kg per body surface area burn. Modified Brooks is in between. It is 3 mils per kg, 2 mils per kg body weight per body surface area burn. And this is actually shown to have lesser amount of fluid requirement without causing excessive mortality. So at the time, most of the centers are following a modified Brooks, which is 2 mils per kg per body surface area formula. You can also use hypertonic saline. It has been used historically. You can use colloid-based resuscitation as well. Now, there is another rule of formula. I have told about Wallace's rule of 9. So, Wallace's rule of 9, rule of Palm, and rule of 10. So, after you have calculated the body surface area, rule of 10 tells us that if your body surface area is X into 10, that would be the amount of fluid for the initial period per hour. So if a 60 kg body weight person, 60 percentage body surface area is burnt in an adult male patient, 16 to 10, 600 ml per hour will be the initial rate at which you should give fluids. Then obviously it is individualized. If the patient is obese more than 80 kgs, then for every extra 10 kgs you add 100 ml. So this is one of the hacks, one of the important formulas you can memorize. There is another formula known as Galvin-Stone, not so important. And studies have found out that using this rule of 10, which is much more less complicated as compared to your modified Parkland and modified Brooks, Parkland, etc., is quite handy. It can also be used. Coming to some of the how will you calculate Parkland if you don't memorize the formula, you can simply take a printout of this nomogram, and then supposedly patient is having 90 kgs, you take a strip of paper and you press the and put their ages across this 90 kg suppose, and total body surface area burn is 40. So you connect the 90 and the 40. What you get is volume to be infused here and time to be infused here, along with what is the time period remaining. So you will get every bit of information from this chart. And one thing to remember, the time that we are remembering, we are mentioning is the time from the inciting event, the time from the burn, not the time of hospital admission or first consultation. This is what is mostly the fluid amount or the body surface area wise is done, the different formulas. The type of fluid, needless to say that across all spectrum of critical care, crystalloids are the preferred one. For burns, ringer lactate is preferred. There are two areas where ringer lactate is preferred unanimously. One is pancreatitis, one is burns. Again, if you are talking about colloids, you should avoid colloids like dextran, starches, but you can use albumin. And there is a beautiful concept known as the IV index. I don't know whether it is mentioned here or not. I want everyone to write it down and read for yourself. IV index is IVY. What is IV index? Basically, if supposedly a patient has come, you are given fluid. Now what you are monitoring is essentially your hard parameters, heart rate, blood pressure, and urine output. If despite giving adequate fluids, you see that the urine output is still on the lower side, and you have to keep giving fluids as much as 6 mils per kg per body surface area within 12 hours window, means you have done a projectory and you are seeing, okay, by 12 hours I'm requiring more than 6 mils per kg per 12-hour window, then you are exceeding something known as the IV index. So that is the IV index. The importance is that if you are exceeding the IV index, then you have to switch over to colloids, and that is 5% albumin. So in that case, you have to decide, okay, I am giving supposedly 200 mls of mils of fluid per hour. I will divide it one third, two third. One third I will give colloid, two third I will give crystalloid. So one third I'll give albumin, 5%, and two third I'll give crystalloid. So this concept is known as the IV index. This is a very important concept for fluid resuscitation. And the pathophysiological phenomena is known as the fluid creep. What is fluid creep? Creep means is the if you do a process and the process begets or leads to the same process happening over and over again. This is known as creep. Like if someone is accustomed to the term known as vancomycin creep, MIC creep. Similarly, the more fluids you give, the more fluids you require. So to that is the why this happens is because the more fluids you give, the plasma oncotic pressure reduces, causing intravascular volume depletion. At the same time, your extravasation of fluid also increases, causing an intravascular fluid depletion again, causing more and fluid requirement. So more and fluid you have to give, and in return you are getting nothing because entire thing is going into extravascular space, causing pulmonary edema, gut edema, etc. So here you have to go for an albumin rescue. Generally, this happens within the first 24 hours. If your 24 hours is crossed, there is no role of giving an albumin per se. So another important concept about blood transfusion, it is mostly corroborative or rather extrapolatory that if patients require blood, they have worse outcomes and a worse infection. But whether the blood is causing the damage or whether they are more sick, that's why they require blood, nobody knows. And one important thing is that cooling. So remember, if the patient has come with burns with raised temperature, you have to apply cool fluids over the patient's body and to reduce the temperature, to reduce the evaporative loss. But your ambient temperature, the room temperature where you are managing, your ICU room, isolation room, should be higher than normal. Why? Because imagine a patient with burn having an evaporative loss. Evaporative loss is based on the radiation. I mean, mostly evaporative loss is radiation mediated, and black body radiation tells us that the temperature difference between the two body objects is what determines the rate at which radiation happens. So, if your difference of temperature between the body and the ambient temperature is more, there will be more loss. So, if you increase the ambient temperature, your radiative heat loss or evaporative heat loss will reduce. Coming to secondary survey, during the secondary survey, you send the blood grouping cross matching, you do the trauma survey like that, you apply the antimicrobials, topical ones like the silver sulfadiazine and the mefenite acetate, Daikin solution, etc. And you call the plastic surgeon as soon as possible to address the wound and and do the dressing and plan ahead for the wound debridement and excision. There is an important thing to remember while during doing the primary survey and going towards the secondary survey. If you see that there are deep partial thickness deep burns, not partial, deep burns involving muscle and bone, that has caused significant eschar. Eschar is the hard, blackish, parchment-like or rubber-like consistency of the skin that happens because of very deep burns. What this causes is it causes entrapment. Supposedly here you see that this eschar has occurred in the hands. The entire hands will go into contracture. If the eschar happens to the neck can go into contracture and patient can die of asphyxia. It can happen to the upper abdomen and can cause a chest contracture. Whenever you come across an eschar, you have to go for an eschar. Anyone who is managing the burn patient, it has to do an eschar. This is an emergency procedure. You cannot wait for the surgeon to come and do. Very simple, you just have to put deep incision over the eschar. So indications is that if there is a chest or vascular compression, suppose the eschar on the upper limb like in the hand causing a radial artery compression and ischemic limb, you have to immediately put eschar. Simple, just use your blade and do 3 parallel few deep incisions that will release the pressure in the compartment. Like for example here, if you got an eschar over the upper chest, you have to release them, otherwise it is very difficult to ventilate them. After the initial resuscitation phase is over, you are coming to fluid resuscitation in the second phase. Like after the initial, in the second or the third day. There it is mostly, it's dynamic and individualized. There is no hard and fast rule. You have to look at the urine output. You have to maintain 30 to 50 mils per hour of urine at least. You have to look at the electrolytes. So you have to look at the other parameters like heart rate, blood pressure. And if you are seeing that there is a runaway phenomena like there is increased amounts of requirement of fluids, you have to give albumin as I previously stated. Now, after that, patients, you are now addressing the patient's other things like you are addressing the multi-organ dysfunction. They can have multiple problems that will come one by one. The target for urine output is 0.5 to 1 mils per kg per hour for adults and 1 mils per kg per hour for children. Supposedly in the day 2, we are seeing that despite giving fluids, your urine output is inadequate, less than 15. You have to evaluate the patient, look for anything that you are missing, look for obvious signs of hypovolemia clinically, and then you have to increase the fluid rate by 20% or 200 mils per hour. If your urine output is there, but it is around 15-25, then you increase the fluid by 10% or 100 ml per hour. If it is between adequate 30 to 50, you keep the same rate. This is a wrong return. This is not increase. This is keep the same IV rate. Similarly, if you have increased urine output more than 200 ml, you don't need that much amount of fluid. You can curtail the fluid rate by 20% or 200 ml per hour. Gradually, you can reduce it. So this is what we have. And if despite these measures, there is no improvement, then you have to call the physician. You have to reassess volume status, send the urine report, look for any cast, look for acute tubular necrosis, why the urine is not coming, call the nephrologist and ask for a renal transplant, renal replacement like dialysis if required. Phase 3 is what we are dealing with after the initial period is over. Is mostly related to the wound care and the infection part. So temporary wound dressing, DVT prophylaxis and infection part, and phase 4 is the rehabilitation part where something known as a hypermetabolic syndrome is important. Now burn wound management in phase 3. So there are various kinds of dressing. This is mostly important for the surgical counterparts, not for us. Just to name a few, superficial wounds are generally covered by dressing materials. Extensive superficial wounds they require topical antimicrobials, and deep wounds they require excision and drainage, as required excision and then uh, 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 replacement. That could be a allograft, or could be a xenograft, or could be a skin graft. Various ways that you can cover the burn area. Now, important thing to remember here again, another concept. If you have a burn patient who has deep burns, don't wait for your conservative management to take care of the wound and then it will heal. It will never heal. If the patient has partial deep thickness to deep burns, ask the surgeon to operate immediately. Just remove the dead part or the scar part and the deep part and harvest. Now, if there is extensive burns, you need skin harvesting. So you need a skin banks, skin donor banks, or you need skin substitutes like amniotic membrane, xenografts and allografts, so and so. And so the trick is, if you want to go for an extensive repair, go as early as possible within 24 to 72 hours before an infection sets in. After 24 to 72 hours, definitely there is colonization of bacteria. You cannot touch the patient's skin. You have to wait for at least 2 weeks, or at least till the time your infection is settled, and then only you can do. So the proper surgical timing is either very early within 24 to 72 hours or late after 2 weeks. Measures to reduce bleeding during surgery: you can infuse lignocaine infusion, lignocaine in the EDR, you can go for hypothermia, limb elevation, various things. Ideal dressings, I'm not going to this detail. Various type of dressings are there. You can just go through. I'll share the PPT, not so important for our purpose. Pain management. Pain management in acute pain in patients with trauma, they will have severe pain. And the pain has various components. They will have a visceral component, they will have a superficial component, they will have deep pain, superficial pain, itching sensation, burning sensation, everything. So they will have a visceral, superficial, and or parietal, along with a neuropathic pain as well. So the primary pain mechanism, pain analgesic, rather not painkiller, is opioids. IV opioids are the primary mode of tackling the intense pain. But one of the important drawbacks of opioids is ileus, and burn patients have got very high chance of ileus as well. Like the spinal cord injury patients, as I said, these patients can also have ileus. So initial acute phase, it is okay to use opioids, but after 3 to 4 days, you have to reduce the dose of opioids. Use a lot of paracetamol, NSAIDs, SOS, and the important drugs used for the during the dressing of burns patient. During dressing, they can cry in pain, they can shout because this is extremely painful. What we can use is ketamine. Ketamine, dexmedetomidine are very well utilized during this period. Uh, After the other than that facts, if you have a localized burn, you can use regional anesthesia, you can use catheters, burn catheter, etc. can be used. Now, important is to remember that when you position a burns patient, there is a particular way you have to position, because if you just keep the patient without attending to its details, they will develop burns. They will not move their body because they have intense increased pain. The dressing will also attach to their underlying wound. That is so much of pain. They will not move and they will develop burn contractures. Therefore, you have to maintain in this way: head 30 to 45, neck slightly extended 15 degrees, shoulder extended 90-degree abduction, meaning to say this is in anatomical position that you have to maintain the patient in order to reduce the chance of contractures. Burns patients sometimes can have coagulopathy similar to trauma. Mechanism is almost the same. You have to go for a simple coagulation parameter test in the initial period, but they're mostly hypercoagulable. They're much more hypercoagulable than coagulopathy. And thromboprophylaxis is mandatory in these patients. If you don't give them, almost 60 to 80% of them develop DVD. DVD prophylaxis means, I mean, chemical prophylaxis that we're talking about. You have to use enoxaparin, not heparin. Now coming to what are the use of antimicrobials here. So if any patient having got more than 20 to 25% partial deep thickness onwards burns, electrocuted injuries or significant burns, they can also have infection. Antimicrobial prophylaxis is a doubtful thing. There is not much of an evidence to use a prophylactic antibiotic. So burn patient comes and you start them on augmenting. There's no evidence to support it. Generally, what we are using most of the time for topical antimicrobial is silver sulfadiazine. It is a historically proven product that is useful for burn dressing. It kills almost many antimicrobials, agents like your gram-negative organisms, Proteus, Pseudomonas, Klebsiella, gram-positive Streptococcus, Staphylococcus, and also fungal organisms. But recently, there are many reports of resistance against this, and there are some corroborative evidence to suggest that use of this associated with increased mortality or worse outcomes. Later on, it was found out that they can cause neutropenia. So there was some speculation going on about the use of silver sulfadiazine. Later on, a balance kind of was maintained that if you have a deep-seated wound, if you have significant chance of colonization, then you have to use silver sulfadiazine. If you have a superficial wound, very, very superficial, you don't need to go for silver sulfadiazine because then it will cause more harm. Burn wound sepsis can cause death, and you have to send cultures and burn wound swab, obviously, in order to get to a bottom line of the infection. When you are choosing an antibiotic in a burn patient has an intense inflammation in the initial period, causing increased volume of distribution. Therefore, you need a higher bolus dose of the antimicrobials. And the same time in the initial period, they will have a hypodynamic state. The cardiac output will reduce, the organ perfusion will be reduced. So you cannot give them anything in the NG or IELTS tube. It is avoidable. Second thing is that you have to give it in a lower frequency because their metabolism rate is also lower in the initial period. But on the after day 5 onwards, they go into a hypercatabolic state when they have increased inflammation, increased catabolism, increased blood supply to the end organs, and increased cardiac output. Here you have to give them antimicrobials at a higher than normal dose, and you have to go for more frequent dosing. These are the dosing recommendations for the burn patients. This is, as same as that of normal patients. Not much of a difference. Coming to burn patient nutrition. Nutrition is very important. Early enteral nutrition is mandatory. So put a rice tube and as early as possible start the nutrition. Now, I'm not going to the depth of the individual concepts. These patients in the initial period are also hypercatabolic. After 5 days also are hypercatabolic. But the initial period is also characterized by insulin resistance. So if you give too much amount of feed in this period, that will be detrimental. So start slow, but gradually pick up and go to around 100 to 150% of the energy requirement by 3 to 5 days. That's what we actually follow. These patients can have high risk of gastroparesis, peristaltic ileus, paralytic ileus, so those has to be taken care of. And stress ulcer prophylaxis is mandatory. These patients can have significant chance of duodenal stress ulcer and bleed like hell. They can go into severe, significant hemorrhagic shock. So stress ulcer prophylaxis is mandatory for these patients. Even after the initial acute period is over. Many times we have seen second week, third week also they have developed stress ulcer and bleed. Another thing, these patients can have two types of ulcer. One is stress ulcer, two types of cancer, skin cancers. One is the cancer arising out of the burn wounds, and one is arising out of the ulcer, stress ulcer. So one is known as the Curling's ulcer, previous one, and one is known as the stress ulcer, is known as the Cushing's ulcer. This was previously in our MBBS day, this was taught, but Curling's ulcer and Cushing ulcer is what is seen. And recently there has not been much of a change. Initial period we can go for some amount of hypocaloric feed, but later on we have to catch up and we have to go for 2 grams per kg per day of protein at least, or maybe better. Initially there was some evidence to suggest that glutamine administration along with your your protein requirements was beneficial, either enteral or IV. But later on, the large trial has come and refuted the claim that glutamine no longer is having significant benefit in burns patient. However, ASPEN and ASPEN guidelines, since I think last published in 2022 or 3, and they were not updated after this publish of this recent trials. They still recommend the use of glutamine in burns patients. So nutritional algorithm is that it's pretty simple. If you have a patient where we can put a RILES tube, you put it, start the nutrition emergency. If the patient is able to take, swallow immediately, then you can keep like that. And if the patient is not catching by, you can put a RILES tube along with an oral feeding. After 5 days, they go into an hypermetabolic state, as I said. So in this phase, there is increased catabolism. And in this state, the metabolic rate rises very, very disproportionately, where you see hyperglycemia, loss of body mass, negative nitrogen balance. So during this stage, you can see hyperglycemia, we have to manage with insulin. This is mainly because of the increased amounts of metabolic stress related factors and inflammatory factors. So here what we can do is we can go for during this stage we have to mobilize the skeletal muscles. Otherwise, these patients can have hypertrophic ossification, contractures, DVT, etc. And you have to prevent a loss of muscle mass, because loss of muscle mass associated with prolonged stay, increased chance of infection, lack of wound healing, etc. So in this case, you have to go for early surgical consultation if you have a surgical thing to address, and 3-4 drugs which you can use in the hypermetabolic state. One is anabolic steroids. Oxandrolone, dosage 10 mg BD in adults. You have to check your liver function test before you give oxandrolone. You can also use non-selective beta blockers like propranolol to reduce the heart rate at this stage, and also they have a protective effect on the metabolism, and the hypermetabolic state is also reduced in them. And you can also give adequate nutrition. Pain control is also important. Now coming to complications of burn injury, very small things like at the last. One is multi-organ dysfunction syndrome that can happen with any patient. AKI, initially hypovolemic, later on acute tubular necrosis. If you have an electrocution injury with muscle burn, you can have rhabdomyolysis. So many causes of AKI is there. Now an interesting part is inhalational injury. Now if you can remember, I was talking about air intubation in these patients, and there are 2-3 scenarios where you have to intubate preemptively. So if you have suspicion of inhalational injury, we can diagnose and categorize inhalational injury by use of a bronchoscope. You do a fiber optic bronchoscope, keep the patient awake, simply go till the through the nose and look at the vocal cords. If you see that the vocal cords and downwards is all blackish, filled with soot like materials, you immediately intubate the patient. Don't wait later. Why? Because these patients are going to have airway edema that is going to increase with time. Secondly, this you are going to give them a lot of fluids, and this fluid is going to accumulate, cause further worsening of the airway. So if the patient has stridor, difficulty in respiration, type 2 failure, anything above that, or significant airway burns, intubate them as early as possible. Don't wait for the later on for their deterioration. So upper airway, erythema, ulceration, edema, intubate as early as possible, and use a narrow bore tube if you have difficulty. Use awake fiber optic if the patient is awake. And if the injury is so significant that goes very deep inside, that can cause clogging of secretions, that can cause extensive sloughing of the airways, that can cause tracheoalveolar fistula, alveolar pleural fistula, and ARDS. It is one of the important causes of ARDS is inhalational injury. We have to remember that. So parenchymal injury can lead to ARDS, atelectasis, pleural effusion, etc. Now, two interesting things that we see in burns patient. Patient has come to you. Patient is not so much of burns, only 10-15%, but patient is suddenly obtunded. Patient is GCS is E1M1, drowsy. The reason could be either of carbon monoxide poisoning or cyanide poisoning. These are part of various chemical combinations. It can be found in batteries. It can be found in various household materials. And carbon monoxide, especially if you have something burning inside your house, and if you have a closed door burn injury, obvious burn injury. So if you have a closed door, carbon monoxide builds up. So carbon monoxide poisoning and cyanide poisoning are differentials in particular scenarios. What will happen in carbon monoxide poisoning? Mainly CNS effects. So they will have blurring of vision, obtundation, vomiting, and then death. Whereas cyanide poisoning, they will have, both of them do not have cyanosis. They will have cherry red color skin. Their skin will be absolutely reddish, but they will have hypoxia at the cellular level. Cyanide poisoning causes refractory acidosis, hyperlactatemia, and in these cases, a narrow A minus A gap that I will explain later on. So carbon monoxide poisoning, if you're dealing with, first of all, you address that there is a carbon monoxide poisoning, intubate the patient, give higher oxygen because carbon monoxide is avidly bound to hemoglobin. If you give higher oxygen, that will replace the carbon monoxide bind to hemoglobin. And if you give higher oxygen at higher pressure, that is the basis of hyperbaric oxygen therapy, it is found to be associated with swift response. So you have to do that. You have to also measure the carbon monoxide levels by the means of co-oximetry. Okay, carbon monoxide levels. If your carbon monoxide levels are above 60, it is lethal. So there are various ways it can remember. Less than 10, it is no symptoms. More than 50 to 60 is lethal. 10 to 20, mild blurring of sensation, mild dizziness. 20 to 30 is usually some drowsiness. And more than 40 patients have vomiting, drowsiness, progressive stupor, etc. Treatment is ABC, intubate, higher oxygen, hyperbaric oxygen therapy. The target is to reduce carbon monoxide below 25% in normal patients, less than 20% in pregnant patients. In cyanide poisoning, what happens is cyanide goes and attaches to the electron transport chain. And because of the electron transport chain attachment, the cells cannot utilize the oxygen that is already available to them. That is causing a histotoxic hypoxia. So because of that, they are not utilizing the oxygen. The cellular oxygen is high. So the the venous oxygen level is actually high. So the arteriovenous oxygen gradient is actually narrow in these patients. In other patients, it is wide, but in this patient, it is narrow. Other clinical signs is refractory shock, significant metabolic acidosis despite resuscitation, and hyperlactatemia are the signs that your cyanide poisoning is happening. Treatment is three things. Give hydroxycobalamin as a sole agent or combine hydroxycobalamin with amyl nitrite and sodium thiosulfate. The dosage is very difficult to remember. Just remember one thing. In these cases, hydroxycobalamin or vitamin B12 is given at a very, very high dose. Normally in ampoule, what we give in vitamin B12 deficiencies comes in micrograms. But here, why we have to give in the range of grams, almost 10 to 12 grams. So it is very difficult to procure. So this is the inhalation and injury protocol. Other than the managing the intubation, all this gaseous or intoxication part, two things are important. There is some role of inhaled nebulized heparin, unfractionated heparin, around 5 to 10,000 units every Q 6 to 8 hourly, and nebulized NAC, N-acetylcysteine infusion in these patients, along with obviously lung protective ventilation, adequate physiotherapy, mucolytics, clearance of the airways, and suctioning, doing a bronchoscopy. These are important. Cardiac issues, not so much. Initial period, as I said, myocardial suppression. After 5 days, increased myocardial workload. More than 150% of myocardial demand can happen in these patients. They can have non-specific hepatic transaminitis. That is simply because of the multiple issues like high direct ischemic injury, cardiac failure, etc. Multiple causes. Hematologically, they can have coagulopathy or hypercoagulable state. They can have infection with significant massive blood loss because of thrombocytopenia and significant blood loss because of that. One important thing to remember, these patients between 2 to 5 days, they can have a leukopenia. This is not to be confused with sepsis. They don't have sepsis at this point. They generally is a benign sign because of the increased inflammation. They have bone marrow suppression and leukopenia. This is a very common finding in these patients. Neurologically, other than gaseous intoxication or trauma related, they don't have any other issues. And excessive fluid resuscitation can cause cerebral edema. GI system failure, they can have gut edema and ileus. This I've already discussed. Airway edema I've already discussed. Extremity compartment syndrome. Again, excessive fluid resuscitation can cause extremity and abdominal compartment syndrome. Orbital compartment, cerebral compartment, and all specific to that. Burn wound and sepsis. Wound colonization. There are three ways in which you can have an infection in burn wound. One is that wound colonization. So only the wound is colonized, but they are not having an infection. You send a wound swab, you get a colony count less than 10 to the power 5. If you get a colony count more than 10 to the power 5, but the blood culture is sterile, that means the patient is having an infected wound where you have sign symptoms of erythema, cellulitis, etc., and pus-like discharge. And if you have full-blown sepsis, fever, tachy, SIRS response, hypotension, blood culture positive, that is invasive infection. In India, the most common agent causing an invasive infection is nothing but Pseudomonas, but nowadays, Acinetobacter is coming up big time as a causative agent. So, which is the criteria for diagnosing burn wound sepsis? So, as I said, sepsis in this patient is tricky. In the initial period, they will have tachycardia, they will have hypotension because of fluid depletion, they hypotension because of cardiac dysfunction as so. They can have various other non-specific findings. So you might confuse with sepsis. So if you get a wound positive culture or colonizer with a blood culture, any of the above, you can diagnose them as sepsis. And clinical parameters, right? You need to have three out of the following: temperature, persistent fever, tachycardia, tachypnea, hypotension, and important to remember, thrombocytopenia, hyperglycemia, intolerance to feed. These three are atypical signs of an infection in these patients. Antibiotics, nothing so much. It's based on the universal, based on the hospital to hospital, their antimicrobials. Mostly it's gram negative. Very rarely you send the gram positive organisms. Other than these usual complications, you can have a hypertrophic keloid, you can have hypertrophic ossification, but these are generally chronic problems, generally seen after 3 to 4 weeks of burn care. So this done. This is done with the burns. More or less, it is done. Yes. Any questions? Any? This was any on the above said topic. Any queries you have, or from the last topic, especially on traumatic brain injury? Since in the last class I covered abdominal and brain. I think brain was not covered point wise, but extensively I could not cover. So anyone has any doubt regarding any concepts?
Hello, sir. You didn't share us the slide share, the PowerPoint presentations of the previous two
Actually,
classes.
I have shared with the organizers, and I don't know from beyond that what happened, but I shared the PPT of that class on the same day itself. So you can ask the organizers about that. And this class also I have clubbed along with the other classes. So I will again send this. This will have everything including trauma and burns. So you can have a read for yourself. So any other question, any doubt? Okay, I guess I think burns is an important issue. Burns, people are not aware of the actual management of burns. Very frankly saying, because very small few centers in India is actually equipped well with the burn management. So do give a read. MCQs, I don't think other than the fluid resuscitation formulas and few here and there details, they won't ask much. Conceptually, there are multiple things to read. I have gone in a bit depth because it is a difficult topic to grasp when you will not see much of it in normal textbooks. If you go and you can read it in O's manual, there is much something given about burns, but in majority of the critical textbook, there is not much of a mentioning. That's why I've discussed in details. Okay, then I guess that's it for the day.